So this morning I'm going to speak about what your dentist would like to know about scleroderma. And a few years ago, I changed my talk from what you need to know about scleroderma and oral health to what your dentist would like to know about scleroderma, and I'll explain why. So first of all, here's my resume. I teach full-time at Tufts University School of Dental Medicine. I just sold my practice in April. So now I still am in my practice a half a day a week, primarily to take care of my scleroderma patients, and, but also to take care of people that I've been taking care of for the last over 25 years. I started working with the Scleroderma Foundation in 2005, 10 years ago. I was invited to speak at this national meeting because the dentist who was going to speak there, at the last minute, there was a health issue in his family and he had to stay home in Texas to take care of, I think, his mother. And someone out of the blue asked me if I would speak at this meeting on Sunday, and it was Thursday morning and I was getting ready to leave on vacation. So I had some experience with scleroderma, not a lot. I downloaded a lot of articles, I read up on it, I came up with a PowerPoint. They sent me that doctor's PowerPoint 10:30 Saturday night, 2:30 in the morning. I had it all rewritten, and one or two of those slides are in this presentation, but everything else since then has changed over the last 10 years, and PowerPoint has changed a lot too. So immediately, the very first question that a woman with scleroderma asked me after that first talk, Carol, who just happened to be sitting right about here, said, "I've probably had scleroderma for 15 years. I was just diagnosed with it. I told my dentist. He said, 'I'm so glad that you know what the problem is now, but you have to see a specialist. I don't know how to treat that.'" And the first thing that went through my mind was, that's terrible. That dentist is the specialist, and he should know what to do. There isn't really that much to know. Over the next few years, I kept hearing that story over and over again. By the way, I found Carol, one of my colleagues, to take care of her out in western Massachusetts near where she lived, and he's still 10 years later taking care of her. And I've learned a lot from his experiences with Carol. But a few years later, I worked with Daniela Phyllis, who just graduated from our orthodontics program. So I started working with her when she was a second-year dental student to do a summer research project. And her summer research project was to survey scleroderma patients primarily at the meeting in Boston in 2010. And, or maybe it was 2000, yeah, it was 2010. We surveyed 350 scleroderma patients to find out what their experience was in obtaining oral health care from a dentist. And what we found was about a third have difficulty just finding a dentist to take care of them. And we said that if you had to call 3 or more dentists just to find one that would make an appointment for you, that was a problem. Almost 2/3 wouldn't recommend their dentist to treat other people who have scleroderma. Now, what's interesting about this is this year I'm working with a dental public health student. So this is a dental student who is also working on a public health degree concurrently. And what he found out, surveying a similar survey with people who have myasthenia gravis. And myasthenia gravis is another autoimmune disease that affects about the same number of people as are affected by scleroderma. He found that they do not have a problem finding a dentist to take care of them. So it's interesting that we have these two autoimmune diseases that affect about the same number of people. It's difficult for people who have scleroderma to find a dentist to treat them. It is not so difficult for someone with myasthenia gravis to find a dentist, and we're going to have to figure out why that's so. I followed this up with a survey of dentists to find out what the problem was. I'm going to skip through some of these slides, because I don't think that we need to delve into this too deeply, but what I did find is that in Massachusetts, because I surveyed dentists in Massachusetts, 93% felt that it's our responsibility to treat patients who have scleroderma. Only 71% felt prepared to treat patients who have scleroderma. And something interesting about that is it's my opinion, and this is an opinion, not a fact, dentists in Massachusetts should be more well prepared to treat patients who have scleroderma, because we have 3 dental schools in Massachusetts, Harvard, BU, and Tufts is the 2nd largest dental school in the country. We have the Scleroderma Foundation, the national office, based in Massachusetts. So I would think that the results that we get from Massachusetts dentists should be better than dentists in states that have no dental school, or states where there are fewer dentists. And by the way, in Massachusetts, we have something like 8,000 dentists in that tiny state. So 71% feel prepared to treat someone who has scleroderma. 50%, half of dentists in Massachusetts feel that if we don't know enough about scleroderma, we might hurt somebody, and which, by the way, is not true. We're not going to hurt anyone by not knowing that much about scleroderma, but it's important. But this is an important factor, because if you think that not knowing about scleroderma will make you cause a problem and hurt someone, if you think so, then you probably don't want to be treating them. And also, 71% feel that treating someone who has scleroderma might be time-consuming. And I can tell you, after treating many people who have scleroderma, it is. But that's OK. All right. So I asked dentists a lot of questions. I said, if someone came to your office and they had scleroderma, what would you do? And half of them said that they would treat the patient. And 40% said they'd treat the patient. Half said that they would want to get more information, which is important for this talk. I didn't think to ask, after you get more information, what would you do? Then I asked them questions about scleroderma to find out what they know. This has to do with one of the questions I asked. And what I found is that if you answered these 3 questions correctly about scleroderma, you were way more likely to feel prepared to treat people who have scleroderma. So knowing about scleroderma makes you more comfortable to treat people who have scleroderma. Then my last question was, if you would like to learn more about scleroderma, how would you like to do so? And 96% of dentists said that they would pick a way or more than one way to learn about scleroderma. And these are the techniques that I would teach people about scleroderma. And you can see what their choices were. And of course, it adds up to more than 100% because some people check them all off. This is your opening. Because what I've seen over the last 10 years is that people who have scleroderma know more about scleroderma than their physicians, know more about scleroderma than their dentists. The dentists are open to learning about it, would like to know about it, and this is what dentists need to know. By the way, last year, one of my public health students surveyed all 60 dental schools and found out that nearly every dental school teaches their students, their pre-doctoral students, people who aren't dentists yet, about scleroderma, but only about half will teach people who are already dentists about scleroderma. And when you think about it, as a dentist, you might not see a patient who has scleroderma for your entire career, or you might go 25 years into your career and then see your first patient who has scleroderma. And is it at all possible that you would remember that 3-hour lecture on autoimmune disease with that 4 sentences about scleroderma? Probably not. So how are you going to learn about it? So what do you think your dentist wants to know? Scleroderma affects your oral health all these different ways. Scleroderma causes your mouth to be dry, causes pain and difficulty opening, which, by the way, is extremely important to a dentist. If you go into a dental office and your dentist says, please open your mouth, and you don't open your mouth, we think that you don't like us. And it might sound a little funny, but dentists are people, are human beings, and in the back of our minds, if someone sits in our chair and we ask them to open their mouth and they don't open their mouth, or they don't open as big as they can, we think they don't trust us, we think they don't like us, we're wondering what's wrong with us. So it's important for the dentist to understand, even before you sit in the chair, I can only open this big. This is it. I can only open this big. We expect people to open about 2 inches. If you can only spread your teeth apart an inch or a half an inch, that's something that we need to know, and we need to be ready for that, just psychologically. Also, there are a lot of medications that you might take that affect your oral health. There's the psychological effects of having a chronic illness, and we need to know about that because it's not obvious to every dentist that having scleroderma automatically makes you sad, makes it hard for you to practice your activities of daily living. But if you express that, then we'll understand and we'll work with you and be your cheerleaders for, you get up in the morning, got to brush those teeth, got to floss. Here's special ways that you can floss that'll be easier for you. And of course, gastroesophageal reflux disease. And I was just in Dr. Khanna's talk, which was brilliant, about gastroesophageal effects of scleroderma. And he believes that nearly everyone who has scleroderma has some gastric reflux. And I'll talk with you about how that affects your oral health. I keep this slide in my talk because my daughter, who just graduated from optometry school in May, so now it's another doctor leader, and she's a resident at the VA in Providence, Rhode Island. She made this slide for me 10 years ago when she was in middle school. She won an award for being the computer genius for her class. It's basically what I showed you in the last slide. If you go to a younger dentist now, someone who graduated in the last 3 to 5 years, they're going to look at your experience with tooth decay differently from people who graduated when I graduated. So when I graduated, we were all surgeons. We would see the bad part of the tooth, we would cut it out, and we would replace it. Now, what dentists are looking at, what younger dentists are looking at, is something called CAMBRA, or Caries Management by Risk Assessment. So what we do is we ask questions, we look at your health, we look at the medications you're taking, and we decide, are you at low risk for tooth decay, moderate risk, high risk, or extreme risk? Everyone who has scleroderma should automatically be classified as extreme risk, and that means that these younger dentists are going to be treating you a little bit differently. They're going to prescribe stronger fluoride toothpaste, they're going to prescribe calcium paste, they're going to prescribe mouthwashes, mouth sprays to reduce the acidity in your mouth, and they're probably going to want to see you more often. It's a kind of shorthand. They're going to treat your dry mouth, but I think that dentists my age should be treating your dry mouth also. Treatment of xerostomia is symptomatic. We are not going to be able to cure your dry mouth, but we are going to be able to treat the effects of the dry mouth. We can prescribe Cafesol. I'll show you what Cafesol is in a minute, but it's a supersaturated calcium rinse that you can use a few times a day. It makes your mouth feel more comfortable. The calcium gets into the tooth substance and makes it stronger. If you're starting to get a little cavity, it can actually make the cavity go away. There's also a calcium and phosphate paste that I'm going to talk about that does the same thing. It's a little easier to get your hands on, and it's a little bit less expensive. There's artificial saliva like Salivart and Oasis. Salivart you need a prescription for. Oasis is available over the counter. There are many other brands. Artificial salivas are different than salt water. They have moisturizers in them. They have electrolytes in them that help replace your saliva. Sucking on sugar-free candies, particularly sugar-free candies that are sweetened with xylitol. Xylitol is, I'm sorry, I don't have the word up there. It's Xylitol, xylitol. It's a sugar alcohol that bacteria will consume it and will actually die from eating the xylitol because it's non-nutritive. I get a picture of that in my mind. It makes me very excited. And there's prescription fluoride gels and prescription fluoride rinses. And then also something that was developed at Tufts by one of my mentors. By the way, the gentleman who was dean at my school when I was a student, he developed this Cafesol, along with this mentor who noticed that when she was giving patients who had Sjogren's syndrome pilocarpine, it made them salivate more. So they turned that into this product Saligen. And Cevimeline or Evosac works similarly. These are medications that just tell your salivary glands to produce more saliva chemically, and they're pretty effective, but it takes 6 weeks of taking these medications 3 times a day to start to notice an effect. And then it takes about 12 weeks to reach the full effect. Do you like me better in the white coat or the black coat? Oh, okay. So here's the Cafesol. It has these 2 tubes, the clear tube, the blue tube. You mix them together. You have to use it within 15 minutes. So you can't mix it and then save it for a while and use it. And you use 1/2 rinsing on one side of your mouth and then 1/2 on the other side, each for a minute. Here are the fluoride products. Now at Tufts, we're recommending this calcium paste, MI Paste Plus. So it's the calcium paste with the fluoride in it. The way you use this, first of all, you need a prescription for it. You order it online from healthwarehouse.com. Healthwarehouse.com. That's what they recommend. But actually, you can do a search on Google for MI Paste, and you might be able to find it cheaper on other sites. Keep it on your nightstand. At night, right before you go to sleep, after you've brushed and flossed your teeth, you don't use this material to brush your teeth. You just smear it on the fronts of all of your teeth with your finger or with a small toothbrush and go to sleep, leaving it on your teeth. It's made primarily from cheese. It does not taste like cheese. If you have a sensitivity to lactose, that might be a problem. So you'll have to try it and see. But it's very effective at reversing small bits of tooth decay. And if you have a larger cavity, it hardens up the tooth around the cavity. This is talking about taking a medication like Saligen or Evosac to increase your saliva. So this is technical information. All you need to know is even though your mouth is dry because your salivary glands aren't working as well as they used to, we can make them work harder chemically. You have to be careful if you have asthma, if you are allergic to the medication, if you have these other medical conditions like iritis or narrow angle glaucoma, cardiac disease, bronchitis. So discuss this with your physician and with your dentist before taking it. And of course, you do need a prescription. You can pick this up anywhere. The MI paste you can only find online, or if your dentist stocks it and sells it out of their office. Oh, if you're a child or if you're elderly, then there are special conditions or special concerns about using it. Now let's talk about gastroesophageal reflux disease. So just about everyone who has scleroderma has an issue with gastric reflux, even if they don't notice that they have heartburn. Many times, patients will come to see me and they say, I have no problem with acid reflux, I have no problem with heartburn, but I'll look at their teeth and I'll see this. Now, that his teeth are all flat like this, his previous dentist had told him, by the way, this is a young man who does not have scleroderma, but he had been told frequently by his dentist, oh, you're grinding your teeth at night. And he may have been grinding his teeth at night, but what I noticed was back here, he's missing enamel where his teeth do not touch together. He's also missing enamel up here where his teeth don't touch. This is from the acid washing over his teeth and eroding away the enamel. Something else that's interesting, in this case, this patient has little silver fillings, and every filling is about 1 millimeter higher than the rest of the tooth. It's not that the dentist went in and very carefully made all of the fillings just a tiny bit too high. It's that over the years, the enamel eroded away from around the silver filling. In this case, this young woman, I did all of these fillings for her the year before, all of these. And then she came back a year later, and she has another good-sized cavity right here from the gastric reflux. So if you have gastric reflux, it's important for the dentist and the physician to work together, particularly because all of the treatments that we do in terms of fixing teeth, crowns, filling, bonding, these things won't hold up if you're washing over your teeth with stomach acid. There are medications that you can use. Dr. Khanna did a fantastic talk about all the different medications. He especially recommends using proton pump inhibitors like Prilosec and Nexium, Acifex. By the way, I've used those medications myself. It's not only people who have scleroderma that have trouble with acid reflux. And the way that I found out that I had acid reflux is I was getting laryngitis as I was teaching music in Sunday school. I found that I could only sing with my students for about 15 minutes and then I would go hoarse. So the ear, nose, and throat specialist looked down at my vocal cords and found that they were burned from my stomach contents. I had no idea. Yes, ma'am?
In other sessions, they tell you not to use proton pump inhibitors.
That is true. So the problem, there's a couple of problems with proton pump inhibitors. They interfere with your calcium absorption, so it makes it more likely for you to have trouble with osteoporosis. Also, they can affect the balance of bacteria in your system and make you more likely to have diarrhea. Dr. Khanna pointed out that with any medication, you have to weigh risks and benefits. And he believes that for most patients who have scleroderma, the benefit of taking the medication outweighs the risks. But do talk with your physician to make sure that you're not harming yourself by taking too much. But he thinks that people who have scleroderma need to take much more proton pump inhibitor than the average. And he recommends the H2 antagonists as an accessory to the proton pump inhibitors. And then the antacids, one thing I'm going to say about that is many antacids like Tums and Rolaids are sweetened with sugar or something that's like sugar that would cause more tooth decay. It's really important to have the proper diet, a low acid diet. You have to avoid things like tomatoes. Basically, when my ENT gave me the diet and all the things I had to avoid, it's like I had to avoid anything that was good, anything that I liked. Really avoid any kind of carbonated beverage, because they're acidic and they increase pressure in your stomach, causing increased acid reflux. No smoking. Nothing to eat or drink for 2 hours before you go to bed. You might need to have endoscopy to rule out Barrett's esophagus, which can turn into a kind of esophageal cancer. There are oral effects of medications that we need to be aware of. Over 425 different medications cause dry mouth. So you have an autoimmune disease that makes you more likely to have dry mouth, and then many of the medications that you would take also cause dry mouth. And it's very easy to find this out because you just take your medication, you look it up online, look for the side effects, and see if xerostomia or dry mouth is one of the effects. This does not mean that you shouldn't take those medications. It means that you should discuss it with your dentist and your physician so that they can work with you to weigh the risks and benefits. But if your mouth is dry, you are at an extreme risk for tooth decay and for gum disease. Oral lesions. Some medications cause sores in the mouth. Some medications cause an irritation to the lining of the mouth, stomatitis. People who have dry mouth and people who take a lot of antibiotics are going to have thrush or candidiasis. Dentists know how to treat that. We prescribe an antifungal. If you have dry mouth, we're going to prescribe an antifungal rinse. If you don't have dry mouth, we'll prescribe antifungal tablets that you suck on. Intraoral hemorrhage is not such a problem anymore like it was 10 years ago because the medication that causes that, penicillamine, is not prescribed anymore. Dysgeusia, change in taste. That's one of my favorite words. I just like the way it sounds. Dysgeusia, dysgeusia, dysgeusia. This is change in taste. And you can have change in taste just from your mouth being dry. You need saliva to break up food into microscopic particles to carry that flavor to your taste buds. If you have a dry mouth and you eat a mouthful of food, it's going to taste like Play-Doh or like sand. So when you're eating, you might want to have more water. But also, medications can affect your sense of taste 3 different ways. First of all, they can damage the taste buds. They can damage the nerves or affect the nerves leading to the taste buds. And they can also be excreted into your saliva. So, for example, do any of you remember dimethyl sulfoxide or DMSO? It was popular in the 70s. It's an industrial solvent that people used to use if they had joint pain from arthritis, osteoarthritis or rheumatoid arthritis, and they would just rub it on their skin. And the interesting thing was you would rub it on your skin and instantly you would taste oysters. So you couldn't really do a double-blind study on this material because what are you going to do to make people not realize that what you're putting on their skin is dimethyl sulfoxide because everyone tastes oysters? A few years later, it was determined that it was not effective at all and it might actually be dangerous, so we don't use that anymore. But it's just an example of how that can affect your taste. Does anyone take nifedipine? No? Yes. Okay. So nifedipine is very commonly known among dentists to cause your gums to swell. And you have to take the nifedipine. So the treatment is we trim the gums away. It's called a gingivectomy. It's not something that you need frequently, but maybe every 3 to 5 years you go to a gum specialist, they trim away the extra gum, it heals quickly, it's not a big deal, but it's something that you need to be aware of. And doing a good job brushing and flossing reduces the increased growth of the gums, or the gingival hyperplasia. And then there's osteonecrosis of bone. Does anyone remember a few years ago there was a lot in the news about bisphosphonate medications like Boniva and Fosamax causing bone death in the jaw? This is a real thing, but it's also caused by prednisone. It's also caused by having diabetes. It's caused by a lot of different things. And it just happens that someone linked osteonecrosis of bone to this new wonderful medication, bisphosphonates. Having a clean mouth not having gum disease, not having root canal problems, dramatically lessens the frequency of having osteonecrosis or bone death of the jaw. So seeing the dentist frequently, doing a good job at home with your brushing and flossing is very protective. It protects you a lot from that. So if you have to take the bisphosphonate medications, take the bisphosphonate medications. If you have to take prednisone, take prednisone. But do a good job keeping your teeth clean, and you have a much smaller chance of having problems. And then there's microstomia. So there's two different ways that we have microstomia. One way is the circle of your lips becomes smaller because of the tightening from the scleroderma. And also, you can't spread your teeth apart as far. So you might have, instead of the normal 45 to 60 millimeters of opening, you might only be able to open as thick as one finger, like that. And I'm sure that all of you can imagine how much harder it is for me to do the work I need to do if I have to work in such a small space. I'm going to talk about how we can deal with that in a minute. Oh, so I'm going to talk about it right now. There's physical therapy. I'm going to show you pictures of how to do physical therapy to help improve your opening. No one does commiserotomy anymore that I am aware of, but that's something that people have done in the past, especially for oral surgery, where they actually cut the corner of the mouth, do the work they need to do, and then suture it back. I've only seen a couple of people that had that done, but those were very extreme cases, and it was primarily for oral surgery, like if an infected tooth needed to be removed. Patience of the doctor and the patient. We all have to be patient with this. Treating people who have scleroderma is more time consuming. That's fine. We're doing things a little at a time. You might become tired holding your mouth open. There are techniques, there are devices that we can use to help you hold your mouth open. And let's see, flossing with a floss aid, shorter burrs, impressions with smaller and cut down trays. These are adaptive toothbrushes. This Dext brush is an award-winning design for people who have arthritis and have trouble holding a standard toothbrush, but you can see the head is rather large. So if you also have small mouth, microstomia, you might have trouble just getting that in your mouth. This is a Benefit Plus toothbrush, and both of these are available online. I'm sorry that the name Benefit Plus isn't there, but the Benefit Plus toothbrush is 3 manual toothbrushes that are held together in a sleeve. It makes the handle a little bit bigger and easier to hold, and the bristles get the cheek side, the tongue side, and the biting surface of the tooth all at once. So it's kind of efficient. The main thing I like about it is that the handle is bigger. And it's a normal size toothbrush head, actually maybe each head is a little bit smaller. I really like these electric toothbrushes. The Oral-B electric toothbrush, the one that's rechargeable with the round head that goes back and forth, they say it's contra-rotating, and the Sonicare toothbrush with the smaller head. They come with 2 different size heads. You want to use the smaller one on the Sonicare. Using a manual toothbrush is a lot easier for people who have trouble grasping a standard toothbrush because it's a fatter handle. It does a lot of the work for you. You do not scrub your teeth like you do with a manual toothbrush. You hold it on each tooth individually for 2 seconds. So it's 1, 2, and then on to the next one. 1, 2, 1, 2, always pointing towards the gum line. It's very effective. I used to think that it was primarily important for people who have trouble with their hands to use a toothbrush like this, but Oral-B sent me a couple of those to evaluate for myself so that I could then write up an evaluation and publish. And I did that, and what I found after using it for a month, my teeth and my gums were actually better. So not the best reason, just because I say so. I'm an expert in evidence-based medicine. My personal opinion is not good, but I do recommend this. And also, if you look at the Cochrane database, there is a very good evaluation of manual versus electric toothbrushes that say how great these toothbrushes are. Flossing. I know flossing is a problem. Have any of you had your dentist come at you or your hygienist with the floss and it cuts the corners of your mouth? So in my office, my assistants know that for my patients who have scleroderma, we're going to get out one of these. This is called a Reach, R-E-A-C-H, that's the name of the company that makes it, Access Flosser. It has a handle that's sort of like a toothbrush handle. If it's too skinny for you to hold, use duct tape. Duct tape fixes everything. And it has these snap-on bows, each with a little piece of floss. And it's very easy and very effective to floss your teeth with something like this instead of using regular floss. Very easy to get into your mouth, past the corner of your mouth. I learned about this, by the way. I had known about it, but I learned about its effectiveness for people who have scleroderma from a scleroderma patient about 8 years ago when I was speaking in Philadelphia, when I mentioned how important it was to floss, and I got gasps from the audience. And then I said, okay, I don't know. What's the best way to do this? And this woman stood up and said that her hygienist had recommended this for her. So now in my office, for my scleroderma patients, this is the only thing that we use. It's very inexpensive. It's about $5 to buy one of these and about $5 for a month's supply of the little floss bows. And let's not think that we have to be frugal and reuse those floss bows. Let's just use one and then throw it away. And I only say that because my wife is very frugal. This is the water pick flosser. It is not a water pick. It does not spray water. It has a little plastic tail that you insert between your teeth. You push the button, and it buzzes around in between your teeth. It's a pretty effective device. I don't think it's as effective as the Reach Access Flosser. It costs a little bit more, but it's only about $10 to buy the unit, and then about $5 for a month's supply. Some people like it better. It has a little bit bigger handle than the Reach Access Flosser. I think it might be a little hard to get it in between your back teeth if your cheeks are tight. But some of my patients use this and really like it. Of course, if you have extreme caries risk, your dentist should be giving you a fluoride treatment using fluoride varnish 4 times a year. And I don't know about everywhere, but in Massachusetts, Medicaid and Blue Cross Blue Shield will pay for that. This is just a quick note about making the burrs shorter for dentists and using smaller or cut down trays. Here's the physical therapy I was talking about. So you can go to your physician or your dentist and ask for a stack of tongue depressor blades. These cost us practically nothing. I think I buy a box of 1,000 of them for about $10. Each one is about 1 millimeter thick. So you can imagine if you can only spread your teeth apart 25 millimeters, you'll need 25 of them plus. Well, then you wrap a rubber band around it, like Shelley has here, and then you slide one more in. I recommend that you sit on the couch and watch TV while you're doing this, not be walking around, not do this one in the shower. But you just keep this in your mouth for about 10 or 15 minutes, giving yourself a little stretch. You don't want to put so many in there that it's causing you any amount of discomfort. No discomfort, just a stretch. And then this is another really effective technique for increasing your embouchure, or the circle of your lips. You lubricate your lips, cross your wrists in front of you, get your thumbs hooked inside your lips, and then gently stretch your lips up and down like this. And what I've found with my patients who do this, within a couple of weeks, they have increased their opening about 10%. By the way, this is one that you can do. It's more effective if you do it in the shower with the hot water hitting you. I don't know if you want to stay in there for so long doing that, but maybe to get away from the kids. Shelley was so kind to do this. Those two exercises can also be accomplished using these machines called the Therabite and the Orastretch. So these machines, you need to have a prescription from your physician. You need to have medical insurance to pay the rental on the machine, on this plastic machine, and then you pay out of pocket for the little replaceable devices. I don't really get the, I don't understand the marketing model on this, but these are effective mechanisms, and if you have to do this for someone else because they are not able to do those exercises with the tongue depressor blades and with their thumbs themselves, some people really like this. Yeah, oh, and you can find this just by searching online for Therabite and Orastretch. One thing that I want to mention, and I'm going to give you 2 case reports. So when you're looking at evidence in medicine, the best evidence is when we have really well-conducted studies that look at thousands of patients and what the results were from treating them. And collection of studies. This is farther down on the scale of evidence. This is called a case report. So with a case report, I am saying I have seen this with a patient, or with a case series, I've seen this with a few patients. And this is what I'm seeing, and I hope that other people find out about this and look at it, and maybe we can get enough patients together to do one of those bigger studies. So what I've seen is that there are scleroderma patients at a higher rate than the rest of the population, where cells in their body appear to be eating away at their teeth. This is called multiple tooth resorption syndrome. So we know about multiple tooth resorption syndrome, but it only seems to affect 1 in a million adults. With scleroderma, from what I've seen, I think that it affects more like somewhere around 5% of people who have scleroderma, where cells in your body actually start eating away at your teeth for some unknown reason. So here is, I told you about Carol, the woman who was sitting here at my first talk. These are x-rays of Carol's teeth. Carol had a root canal done on this tooth because it looked like on the inside she was getting internal resorption. So the root canal specialist went in and treated the tissue, removed all the tissue from the inside of her tooth, and it continued to be eaten away from the inside out. And then look at what happened to the tooth next to it. And then here's another tooth where it's getting eaten away from the outside in. This gentleman came to my office about 2 years ago for the first time. I took x-rays of all of his teeth. Everything looked great, except right here, he has this cavity. And when I tried to find the cavity, I found it way up under the gum on the surface of the tooth. So this is a periodontal probe. I'm sure that you've all had your gums measured at the dental office. It's a millimeter ruler. I'm holding it right where the bottom of this cavity is. I want to know what's causing that. I want to know what's causing your body to eat away at the teeth. So I did a little surgery. I peeled the gum back. I took the tissue out of there. You can see the tooth is all kind of shiny inside. I put a filling in. I put the gum back over. That's fine. And then I sent the tissue to an oral pathologist. And they made these slides. So it looks like there's a good amount of inflammation here, which you would expect when you have an autoimmune disease. And then there's these little accretions. So here's a blow-up of that section. And this is all fibroblasts here. And here's a blow-up of that little section. And look, here's a piece of tooth taken off the tooth inside that tissue. And what appears to be happening is fibroblasts are coming together and making a kind of cell called a macrophage that eats away at bone and teeth. We don't know what's causing this. We don't know how to treat it yet. But I think that it's important that we have these cases where we can say, look, there's this problem and we have to look into it. And I don't think that anyone noticed that before. So let's wrap up. Oh, and I'm running right on time. That's awesome. When you have scleroderma and you're going to the dentist, what does the dentist need to know? Tell the dentist that you have scleroderma. Tell the dentist the way scleroderma affects you. Please bring a list of medications. It's a good idea to just carry a list of your medications in your wallet or your purse, just in case. You never know what might happen. We need to know what the medication is, what it's prescribed for, what the amount of medication is that you're taking, the dosage, how frequently you're taking it, and who prescribed it for you. It's a lot of information, but it's really important to help the dentist feel more comfortable and feel like they're more knowledgeable treating you. You might want to schedule shorter appointments because it might be uncomfortable for you to hold your mouth open. Although the dentist can use like a little rubber doorstop to help you hold your mouth open. And we can use a rubber dam to help keep things from getting in your mouth. Schedule appointments that are the best time of day for you. So when I was working more often in my office, right now I'm only in my office on Thursday mornings, but when I was working more, my staff knew that I would not do root canals at 6 o'clock at night unless I had a patient who was a scleroderma patient who said, you know what, I need to come in the evening to have my dental work done because that's the best time that's when I feel my best. Do the physical therapy that I showed you right before your appointment because it'll help you hold your mouth open better. It'll help make you more comfortable and it'll make it easier for the dentist to work. Please bring gloves and a blanket to our offices. We have to wear a lot of gear. We have to wear a mask. We have to wear eye protection. We have to wear a jacket. And it's hot for us. So we're keeping the office cool. My staff knows when a patient who has Raynaud's comes in the office, we're going to cut the air conditioner right then so that the air conditioning doesn't blow on them, but the office is already cool. We can make your appointment more comfortable by using a mouth prop. This is an old-fashioned kind of mouth prop, which is actually very effective. So it has these rubbery parts that go in between your teeth, and then you can jack it up, and so it's adjustable. And we can jack your teeth open as much as is comfortable for you and gives us the opportunity to go in. So it looks like an instrument of torture, but it's really much more comfortable than some of the like little green plastic things we might use that look so pretty. Rubber dam, patience of both parties, short appointments and or breaks in the middle of a longer appointment, and asking us to turn the air conditioner off just while you're sitting there. See your dentist regularly every 1 to 4 months when you have an autoimmune disease. Thank you, because it helps prevent you from having more serious issues, and also helps maintain a good self-image if your teeth are nice. This is my contact information. I am absolutely happy if you have a dentist that you like, that you're seeing that has any questions about treating someone with scleroderma, if they were to get in touch with me by email, email is the best way to get in touch with me, and I'm more comfortable with that than a phone call, because then I can send a more considered response, and I can also send attachments with more information.